Okay, so this is a interesting case. So this was the original study in 2018. Okay, and you can see, the patient has very dilated pancreatic duct. And then there's this big complex mass-like structure in the head, which, was read as malignant IPMN appropriately. It was resected and the path came back as colloid mucinous tumor in the background of IPMN, which is like a super rare subtype of adenocarcinoma. So the patient was, this is 2018? Yes, 2018. So then the patient was followed. This is his CT in 2021. So about 6 months ago, you can see that the remnant is very, very atrophic. The duct is not dilated. So this was stable for a few years. And the most recent CT now looks like that. So you can see now that the duct is again dilated and kind of irregular and has a scalloped appearance. And like I thought that you can see here, like it almost has like a texture of like a mass here. It's not just dilatation of the duct, but there's something in it, like if you pay attention carefully. And then this is probably a small obstructing lesion. So I think that this, I don't have path yet. This has just happened last week, but I think this is like, recurrent IPMN. And anyway.
That's interesting. I have a few cases of colloid, and what I learned is that one, like you said, they're rare. And then there's like 4 different types of cancer you can get with an IPMN. I think it's like gastric, intestinal, pancreatic, biliary, and colloid. But colloid is like a mucinous type, and it actually has a much better survival than a pancreatic biliary type. So in general, it has like a 50% survival, 5-year survival.
Right.
And it has a lot of mucin in it.
Right. Well, he's been doing okay for 3 years, which for pancreatic cancer is, is not it's a pretty good thing, Yeah. Okay. So the next person, okay. So on CT, they noticed this lesion here. Okay, which is, looks, and it was a new lesion. So they were concerned that this is a met. And they also noticed that there's some irregularity here, and they weren't sure if this is a true lesion or something, or just an artifact. So they recommended that we get an MR, which we did. And I'll just show you the T2. You can see this is a T2, and this is the first lesion, has kind of evil gray of tumor situation happening. There's nothing happening with the other side. Let me just get a regular T2. Here we go. So again, this evil gray of tumor that Aarti loves. Aarti, I stole this term from you. I love it. And you can see that the second part doesn't really have anything there. If we look at diffusion, as expected, the part where we see the met is very, restricted, and there's nothing happening posteriorly. And this is a fairly decent diffusion.
Victoria, you said they have a primary tumor?
They had rectal cancer.
Okay, got it.
So then I'm just going to bring it up like that. So then because they weren't sure what's happening, they recommended get Eovist, and this is the pre, right? Again, liver looks pretty good. That lesion, is clearly there, and then there's not much happening in the other area. And then again, on contrast, not surprisingly, you can see that original, thing that we're pretty confident is a tumor is a met, behaves like a met, like kind of irregular, hypovascular. Not much happening in the other area. So this is a otherwise healthy liver. So you can see by the second run of Eovist, you're already getting close to transitional phase appearance, where the parenchyma and intraparenchymal vessels look very similar. And then you can see that the liver looks somewhat heterogeneous. And then when we get to true transitional phase right here, the appearance becomes even more apparent. You can see that the parenchyma is just subtly heterogeneous. And when we jump to hepatobiliary phase, now we truly appreciate the degree of abnormality in the parenchyma. So you can see this is otherwise healthy person. They're not supposed to have like normal liver parenchyma on hepatobiliary phase. This is kind of like a more normal appearance here, where the background is relatively uniform, or here, and the only hypointensities we see are vessels. You can see that in the right hepatic lobe, we see very reticular appearance to the parenchyma, and that area that was questioned on CT corresponds to one of these really heterogeneous areas. So, any thoughts?
Is this a finding of like early chronic liver disease?
I'll tell you, patient has 4 months of FOLFOX treatments, and AST and ALT kind of are slightly elevated, alk-phos in 200s.
Oh, is it SOS?
Yeah, I think so. So I think this is like the prettiest case of SOS I've seen, which is called sinusoidal obstruction syndrome. It can happen in the setting of certain, what do you call them? Chemotherapy medications, of which cisplatin-based meds are commonly. And Eovist is the most sensitive modality for detection of this. And this is what it looks like, a very kind of reticular pattern on hepatobiliary phase. And yeah.
Very cool. I had a couple of cases where the surgeons told me after, like from the operating room, like, we have a blue liver. And I was like, I didn't see much on the MR in retrospect. So I like this idea of using Eovist, or I mean, I guess the question is, we don't usually use Eovist, so it's helpful that you see it on this Eovist, but would you generally?
So I think that the literature is fairly clear that when the Eovist is the most sensitive of what we have of modalities for detection of all extra metastases. So in my mind, anytime there's idea of resection, Eovist should be done. And I've seen cases where, you see maybe 1 or 2 lesions, and then you do Eovist and you pick up something extra that needs to be, they need to do something about it, or either ablate or resect. So, so to me that's, there's a lot of data that shows that there should be standard of care. If they suspect SOS, Eovist is probably the most sensitive modality for this, for picking this up. You can't see this on any other phase pretty much. You may see slight heterogeneity on, like as we saw in CT, there was some suggestion of heterogeneity right here. But it's very non-specific, but on hepatobiliary phase is fairly obvious.
Cool. There's a couple of comments. Steve says we try to do Eovist for liver met workup routinely.
Yep.
And Lindsay said, any other special protocoling for Eovist when suspecting SOS?
Nope. Just that's at hepatobiliary phase. You'll see this very, very classic reticular pattern.
Cool.
So this was a case. I don't have the study that before, but it's offline. But this was a new region here, as you can see. Yes, you see it. So this was read as at the time. So this is 65 months prior to the current date. So this was read as a partially thrombosed right renal artery aneurysm, and the patient was referred to vascular surgeon. Vascular surgery did angio, which I don't have the images because it's vascular surgery, but based on the report, they said that they did an angio, they didn't see the aneurysm, then they repeated the angio, or like they did selective catheterization, and then they were able to see the blush and they put the covered stent. That's the story. So then patient, let's see, had a stent and then is sent for follow-up. So this is about 56 months prior to today's date. And now you can see that the stent was placed, but there's no change in this thing. So then this is read as persistent partially thrombosed renal artery aneurysm. And from this point on, the patient continues to get follow-ups, sorry. Let's see. So about every year or so, or sometimes a little closer to each other, she gets a follow-up CT for assessment of this partially thrombosed renal artery aneurysm. You can see here. And then patient, the most recent CT is in February of this year. It's about 5 or 6 years. And now this is what the lesion looks like. And at this point, you can see that A is grown, right, since the original one, and it became much more heterogeneous. So at this point,
I'm thinking paraganglioma, less
yeah,
likely a neuroendocrine.
yeah. So at this point, you know, I think that it's hard to, especially like for residents, it's hard to not to be swayed by what prior reports have said. But it is an important skill to kind of to be able to, and sometimes, you know, the things look a certain way on one study, and then on follow-up they may not look the same way, and it's okay to say, you know, on the current study that's not what it looks like. So that's how we reported and said, you know, in the current study this really doesn't look like an aneurysm, this really looks more like a soft tissue mass. Could you please work it up? And I don't have the path yet, but here's the MR. You can see that it's kind of intermediate signal intensity in T2. It enhances fairly avidly and heterogeneously, and really doesn't follow the signal of the blood vessels. And here we go. There, you can see it right there. And then here's the sagittal. On the second, on the sagittal, you can see it very nicely how it looks like a retroperitoneal mass right there. You can see it doesn't look the same signal intensity as the vessels. Anyway, so this is just a peer learning thing where, again, like the point is not to get too attached to prior reports and kind of assess things critically in such situations. You can see here. Anyway, so I don't know, it's going to end up being either paraganglioma, maybe schwannoma or something like that. You know, we're waiting for biopsy to happen, but it's not a renal artery aneurysm, which is an important thing.
Yeah, I wonder if the blush they saw on angio was just like tumor blush.
I think that's what it was, because it's the mass is hypervascular. So I think that's what it was. They saw the blush they saw the tumor blush, and not being radiologists, they didn't recognize it as a tumor blush, and they just put a stent in. All right, that's all I have for today.
Awesome, thanks. Anyone else? Okay, I'm going to share my screen. Okay, I have a couple of quick ones, and then I have some CCLS cases. So I want someone to tell me what they see here. This is just a nice example. Stop on this image. So we've got some renal lesions and pancreatic lesions.
Pancreatic mets from RCC.
Good thought. Anything else? So you're saying like this enhancing thing here could be the met from this RCC.
Does he have some sort
Yes.
of syndrome like von Hippel or?
Yes, exactly. So this is von Hippel-Lindau. So they've got innumerable cysts throughout their pancreas, which can be a combination of cysts, serous cystadenomas. And then they've got these enhancing lesions in the head, which I'll come back to in a minute. And then they also have all these cystic lesions of the kidneys, as well as renal cell carcinoma of the kidney. So whenever you so this is pretty typical for von Hippel-Lindau. They can also get hemangioblastomas in the spine. But whenever you have an enhancing mass in the pancreas in the setting of von Hippel-Lindau, there's a few things that you can think about. So you can think about a MET from that RCC, but that's actually less likely because these RCCs in von Hippel-Lindau are more indolent, so they're less likely to metastasize. When they start getting above 3 centimeters, they'll start thinking about resecting them, but they basically watch them, actively monitoring them. The other thing you can think about is neuroendocrine tumors, which is also something they get in VHL. And the third thing is a solid serous cystadenoma. And I bring that up. That's a rare type of serous cystadenoma. It's basically like when all the fluid part gets dehydrated. But we have had a couple of cases where we called like concerning for either neuroendocrine or RCC MET, and they were biopsied and turned out to be serous cystadenomas. So in the setting of von Hippel-Lindau, solid mass, I would give all three of those a differential. And I actually put neuroendocrine first, and then solid serous cystadenoma and RCC MET. And they resected this, so they did a Whipple, and these turned out to be 2 grade 2 neuroendocrine tumors. So I just thought it was a nice example. Somebody's saying something. Oh, Steve said VHL. Good, awesome. Is my next case. Also a pancreas case. And I can see the chat so people can chat in too. Oops. So we've got ductal dilation, and then we've got this lesion in the head of the pancreas. Any thoughts?
It kind of looks like a serous cystadenoma, but the duct should not be blocked by that.
Yes, good. So this is a serous cystadenoma. It's got a nice lobulated border. It has a central scar that has calcification, and it has the suggestion of like T2 hypodense, like cystic areas in it. This is the tricky thing about serous cystadenomas is they can look really solid on CT because they have all these vascularized septa. But if you were to do an MRI, which was not done in this case because we just felt confident that this is a serous cystadenoma. But anyway, if you do an MRI, it will be really, really T2 bright like a sponge. You can see a lot of the fluid. This was actually causing recurrent pancreatitis. And I guess my teaching point here is actually serous cystadenomas can cause ductal obstruction. It's not super common, but because their central scar can calcify, it can cause ductal obstruction. That is not a malignant feature. These do not turn into malignancies. Basically just the fibrosis from the central scar and the mass effect can cause ductal dilation. In this case, it was actually resected because the patient was having recurrent pancreatitis, given this ductal obstruction, and the path was serous cystadenoma. So this one, you can see this IVC filter was recently placed. And it's some of the struts are going kind of outside the IVC. That's really common. But the top part of the IVC filter is actually going towards the aorta and touching the aortic wall here. So it was a misplaced IVC filter. And I'll just show you on the coronal. You can see it's like really going at this angle here. So IR went in and removed this misplaced IVC filter, and this is the post removal CT. So you can see that there is a pretty large, it's immediately after the procedure, there's a large retroperitoneal hematoma now, and there's this contrast that is extravasated from the IR procedure. And actually, we don't know how much is from the IR procedure and how much is also just from the CT contrast. So they went immediately back to IR. And you can see that there was like extravasation from the IVC, and they ended up placing 2 stents. Victoria says she's leaving, but anyway, so this is just an example of a malpositioned IVC filter that led to, during removal, led to the laceration of the IVC, and they ended up having to treat it with a stent. This is a companion case, actually kind of a cool one. This patient, they also had an IVC filter that the struts were going outside the IVC. In this case, the IVC filter was kind of like compressed. Part of it was compressed, and then the rest of it was like really expanded. And so some of the struts were going into the duodenum, and then one of the struts went into the aorta and actually induced a little thrombus. This patient was hypercoagulable. They had antiphospholipid syndrome. And so we think that's why they got this thrombus associated with the strut. But anyway, they also ended up removing this IVC filter, and the patient's doing fine now. So once it does go into the aorta, though, it can be a nidus for a thrombus. Okay. And then I have a couple that are related to the CCLS. Do you guys remember this discussion from last week, the clear cell likelihood score? Are you going to participate?
I missed last week.
Okay. But do you know the CCLS, Steve? Clear
Yeah,
cell.
when I think it's going to be useful, I do try to pull it up and use it, but I don't think my urologists are sort of fully on board with it yet. They don't order MRIs.
I'm starting to use it for complex masses. Somebody else going to say something?
Do you use it for CT too, or just MR?
For MR, because I think most of the parameters, and I'm going to bring up the algorithm and I'll show you, but I think most of the parameters are related to MR.
I'm seeing trickles of it. Yeah.
Yeah. So this is a cool case. It's a follow-up to Nellie's case from last week. So we can see that there's several T2 hypointense masses in both kidneys. So there's multiple of them. So multiple T2 hypointense masses. Often when we see T2 hypointense masses, we think about papillary renal cell carcinoma. This is what it looked like on the corticomedullary phase. So it was actually hypointense to the cortex, which will be important for the algorithm. And I measured it because part of the calculator has you calculate it. And then this is the delayed phase where you can see that there's quite a bit of washout in multiple of these masses. On the in and out of phase, they did not have intravoxel or microscopic fat or bulk fat. And then the one point that we talked about last week was the diffusion. So generally, they basically demonstrate some restricted diffusion. You can see that they're kind of bright. And then on the ADC, they're quite dark. So what do you guys think these are? They're T2 bright, T2 dark, and enhance less than the cortex and wash out, demonstrate restricted diffusion, don't have definite fat in them. I can bring up the algorithm. Oops. Okay. So this is the CCLS algorithm, and a couple of things. So here we say there was no macroscopic fat. It is enhancing. It's an indeterminate solid mass. It's hypointense to the renal cortex. And then this enhancement is basically, is it intense, moderate, or mild? In this case, there's actually a CCLS calculator, and I calculated it, and it was moderately enhancing. So it ends up being a CCLS 3, which means that it basically needs a biopsy. If it was intense enhancement compared to the cortex, then it could be a lipid poor AML versus a clear cell RCC. So in any case, this patient actually has, I kind of kept this from you, but they actually have a lot of other, they have like several other. So for example, the lesions I was showing up here don't have fat in them, but some of them do. And this patient also has this appearance of their lung bases.
Yes, lamb.
Yeah, so this is lamb, and this patient has known tuberous sclerosis. So we're presuming that all of those lesions were lipid poor AMLs. But if you follow the CCLS score, they would have been a CCLS 3, and they would have triggered a biopsy. Okay, and then I have a companion case to this. Oops.
Shows you how the lipid poor AMLs are problematic though.
Yeah, but at least if you trigger the biopsy, then you're not going straight to surgery. Okay.
Yeah, I have a question.
Uh-huh.
So where do we incorporate diffusion?
Oh, actually, this is great. So this was, Rupa, were you on last week?
Yes, I was. But
Okay, so we had this discussion about
subscripts, right, for diffusion.
We had this discussion about the diffusion last week, and I remember like Cookie said, like, oh, that restriction is concerning me. And I actually read this chart wrong. So if you're in this category and you're debating between a lipid poor AML and a clear cell RCC, and the arterial to delayed enhancement ratio is high, and you have like a potential AML here, I read this to mean like this 2 to 3 with this E here about restriction. I read this to mean if there's restriction, then you're more likely to make it a 3 and be more concerned that like it's in the possibility of being a RCC and you should, do a biopsy. But actually what this E means is if you have marked restriction, you call it a 2. And so I talked to Ivan Pedrosa about this, and he said that actually lipid poor AMLs restrict a lot. Those and papillary RCCs restrict a lot, whereas clear cell RCCs often do not demonstrate much restriction.
Okay,
And
so it's more of a tie-breaking thing.
Yeah, it's a tie-breaking thing. So actually, if you have restriction, you feel even more confident that it's a lipid poor AML. And the reason why is because they're densely cellular, not just with muscle, they have a lot of muscle and also a lot of vascularity. And so because it's so densely cellular, they tend to demonstrate restricted diffusion.
Well, that's a good nuance that I have not come across before. So
yeah, and also I was telling Yvonne, like I misread like this 2 to 3 with the E up here made me think like, oh, I bump it up to a 3 if it has restriction. But he said, no, look, it says CCLS 2 if it has restriction.
Right, we're so used to bumping things up that it's possible to actually downgrade them using the
you bump
correct
it down.
DWI interpretation. Okay, that's helpful. Thank you.
Yeah, so I thought that was really interesting. And then this next case actually is a good companion. Okay, so here is my next case. What do you guys think about this lesion? It's pretty iso-intense on T2. I'll bring up the enhancement in a minute. And you can see here, this is what the in and out of phase looks like. What would you call this on like, fat-wise?
Looks like intravoxin.
yeah.
Yeah. So intravoxal fat. And I was wondering, like, see how there's like some spaces in there? Like, does that mean there are foci of bulk fat there? But actually what it means is, yeah. So let me pull that up. Why are you asking for that?
To see if there is bulk fat as well.
Yeah. And also another thing you want to look for is if there is hemorrhage. So I would argue it's really faint, but maybe there's some heterogeneity here. So there could be hemorrhage or necrosis here that is causing this part to not have intravoxal fat. But because this is so dark, I feel like sometimes people might be like, oh, this is bulk fat, or maybe there's foci of bulk fat within intravoxal fat, etc. But anyway, so this was the non-con. This is the arterial. And then this is the delay. So what would you call this?
It's washing out on the delay. It's not super hyperintense on the early arterial, right?
Yeah, it's
like there are
actually a
vessels
little bit
going
less
in-
than the than
yeah,
the
cortex.
cortex. Yeah.
Yeah.
What would you call it? And
I'm
we
just
said it has
looking at
microscopic
this.
fat.
Sorry.
I'm looking at this algorithm. So it's ISO on T2.
Yeah, I can bring up
It
the algorithm again.
has, okay, it has microscopic fat. It enhances, it doesn't enhance as much, but washes out more. Is there a diffusion?
So actually, yeah, I would say, I guess it's moderate enhancement, right? Or maybe intense. So actually, here's another thing I wanted to show you guys. There's actually a CCLS calculator. And so you go, is there macroscopic fat? No. Is it solid? Yes. Is it hyper intense? It was basically iso intense. What is the enhancement? And if you don't know, then you can calculate it. So this was 100 on the pre-contrast. Corticomedullary was, let me see. It was 380, and then it goes down to 200. Signal intensity. Oh, wait, hold on. I'm supposed to do the signal intensity of the cortex. Yeah, that cortex was, you can see how this is a little complex, but let me just measure the cortex. 434. Okay. So the tumor to cortex enhancement ratio is 84%, which would actually be intense. So even though it looks like it's a little bit less than the cortex, it actually falls into the intense category. And then is microscopic fat present? Yes. And so this is a CCLS5, very likely clear cell carcinoma. And anyway, this was biopsied and this turned out to be a clear cell carcinoma. So I just wanted to show you guys. And so if we go back to this algorithm, it would have been ISO, intense with microscopic fat. Yes, clear cell RCC5 here.
Nice. This one's more classic because it follows every limb
Yes.
of the algorithm.
But like this whole intense, moderate, and mild thing, I was also confused about that, but I find this calculator to be helpful to tell me like, okay, actually it's 84%.
So rather than doing
Is the calculator on, where do you, I was looking for a calculator. I couldn't find one time. So where do you
Yeah,
get
see, it's cclsrads.com. If you just now Google CCLS calculator, it'll come up.
CCLS calculator? Okay.
Yeah. And then this is another cool thing is back on the algorithm. I also was confused about how to calculate the ADER.
Yeah.
And the calculator will actually help you calculate it if you are in this category. The ADER won't come up unless you're basically have already gotten into this category. But once you're in this category, then it will, and you're intensely enhancing, then this will come up. And
what is
actually,
the inputs for the calculator?
yeah. And okay, this is another really cool thing about the calculator. After you do all this, it actually can help you get an MRI template. So you go here and you basically put in all the other information about the tumor, like the size, location, etc. And once you put all that in, and you press run the report, it actually it makes a report for you and you can just cut and paste that into your report.
Wow.
Isn't that cool?
That is cool.
Mind blown. That's amazing.
Okay, wait. And then I want to show you one more thing. Back on this thing, sorry.
Aarti, hold on one second. Be on this screen for a second. I just have a silly question. But so if we go back to this algorithm, we said it's ISO intense. And suppose we hadn't used the calculator and we had visually said the enhancement is moderate. So why did it skip the limb with the microscopic fat? Yes or no? Suppose we had chosen moderate, would our options only have been oncocytoma or chromophore?
I guess so. I guess
Really?
because renal
Shouldn't
cell
there be
clear
another
cells.
limb that should have fat even for the moderate enhancement ones?
I guess this algorithm is saying that all clear cell carcinomas have
A
fairly
lot of
intense,
microscopic
but like also it's saying they have intense enhancement.
enhancement. Because I feel
every
like if
time
we
you get the
didn't,
clear cell, it's because there's intense enhancement, but that intense enhancement doesn't mean it has to enhance more than the cortex. That's why you need the calculator to say that like that enhancement is, you know, greater
exactly.
than 75%
So
of
visual
the renal
assessment
cortex.
would be a major pitfall
Yes.
because the range is so broad between 40 and 75.
Yep.
And we have to do it by the correct formula method to say what exact percentage enhancement there is, because otherwise the whole differential changes.
Yes.
Nice. Very nice.
Yes. Yeah. And then I have 2 more points. One was about the fat thing. So what Dr. Pedrosa told me was that, so like I was asking him like, okay, what if you think that there's like, what about this microscopic fat? Could a lipid poor AML potentially look like this? And he said, absolutely not. It would not look like this. So he said, absolutely not. It would not look like this because lipid poor AMLs have very little fat. They're mostly muscle and vessels. So they don't have the microscopic fat that a clear cell has. So like, it's not like a lipid poor AML has, instead of having bulk fat, it has microscopic fat. It basically has no fat, or it'll have a globule of bulk fat.
Yeah, that part I had studied, and just before my phone rang here, I was about to call this thing a clear cell, pretty sure, but
And you would have been right. It's just kind
I
of
didn't
tricky
get a
sometimes when there's so much fat like this, it's kind of confusing.
Yeah.
And then I want to show you one more thing. So today they published a multi-center evaluation of clear cell. It was just published in Radiology Today. And one thing that Nelly asked about last week is like, what do these numbers mean? Well, one thing they said was that basically the CCLS has like an 88% predictive value of determining whether something is a clear cell RCC. And it works really well for like the clear cell 5s and 4s. The 2s and 3s, they said they had a very like small number of these. So it doesn't really work as well here, but basically 4s and 5s often will go to surgery. 3 will end up getting a biopsy, and like 1 and 2, you can probably just watch.
I was just playing with the calculator here for a minute, and it's really kind of nice.
Yeah.
It says
Yeah.
enhancement on corticomedullary phase, and you can say ISO intense, moderate, or mild, or help me calculate. And you click on help me calculate, and then you just punch in the numbers of, signal intensity.
Yep. And then say it wasn't a solid mass, then they tell you to go to Bosniak, and then they have like a Bosniak thing here. So yeah, I thought that this calculator makes this, even though it was like confusing before, it makes it like much more approachable. And Rupa says it's cool to have the report as well. Yep.
Yeah, that is cool.
Okay, that's the end of my CCLS refresher. Anyone else have any other cases?
I don't.
Yeah, this is my first time participating. I wasn't planning on showing, but because there were some interesting cases shown, I can show a companion case to one of the previous cases shown.
Yeah,
But
great.
while I pull it up, I can also just talk a little bit about the CCLS, because I'm part of the SAR TFP for RCC, and I've had like a lot of discussions with Ivan on this very topic. So the problem with CCLS and like renal masses in general is that institutional practices are so different. So at the end of the day, it's not going to be as simple as the Bosniak or anything else, or the prostate, in which it's just all institutions follow a similar pattern, whereas CCLS, it's going to be different. Because in the US, many institutions, they just directly take patients to surgery regardless of the renal mass, and they have around a 20% negative, as in 20% benign results, and they just live with that. Whereas in my institution, they biopsy every single mass. Every single mass is biopsy. So my clinicians don't care what the CCLS is before the biopsy, because the biopsy result informs them of what it is supposed to be. So I think that's kind of where each institution should titrate the CCLS to its own specific needs. So for example, if we're practicing in the US, then we should say that if anything is CCLS 4 or 5, okay, fine, yeah, just go ahead with biopsy. Anything 3 or below, don't go ahead, go ahead with surgery if it's 4 or 5, but if it's anything 3 or below, please biopsy at least that before you take the patient for surgery. Whereas in our case, we can do the opposite, as in you don't really need to biopsy every single mass. If it's a 4 or 5, just take it for surgery. But if it's anything below that, yeah, continue with biopsy. And that's kind of the flexibility we have with CCLS. And we kind of need to figure out what institutional patterns are and then kind of go. Because calling CCLS 1 and 2, you can just follow up. Again, that's a slippery slope because active surveillance is a very complex topic in renal masses. And again, there's institutional preferences and stuff like that. So then, like, if institutions want to go towards active surveillance, then those institutions, we can say, okay, these are the masses to pick. So I think at the end of the day, it comes down to what institutional practices are. In my institution, like, we have a good relation with the urologist, and that is actually every week there is a renal mass rounds. There are at least 10 cases discussed, and then we discuss together, and we tell them, okay, for this one, do a biopsy, do active surveillance or whatever. So that's kind of good for us. As regards diffusion restriction on masses, for fat poor AMLs, like, the common confusion is fat poor AML with clear cell RCC. Fat poor AMLs, we know it is just all muscles which are tightly packed together, so they show diffusion restriction, whereas clear cell RCCs generally don't. The other confusion usually in pathology and other things is oncocytoma versus chromophobe, because both are essentially oncocytic tumors, whereas oncocytoma is benign and chromophobe is malignant. In those two, chromophobe shows restriction, whereas oncocytoma does not. Chromophobe shows restriction because it's kind of similar to the thing that in chromophobe, the non-contrast is also slightly brighter because the cells themselves have larger nuclei within them. So it kind of almost looks like they're tightly packed together on pathology as well as on imaging. And that's why they kind of show more restriction. And that's also the reason why Fermin nuclear grading or the ISUP grading is not being used for chromophobe, because the basic nuclear pattern, even for like a low grade chromophobe, is much larger compared to clear cell other things. So diffusion restriction is generally seen in fat poor AML as well as in chromophobes, and generally not seen in others. But as you saw from the multi-center study, the accuracy, like if you want to kind of come down to a diagnosis of everything accurately, that's going to be difficult with clear cell. There's like a lot of exceptions to the rules, and then your urologists are going to hate you because you called it something and it turned out to be something else. But I think it can be used to generally guide strategies in general, if that makes sense.
Yes, that was awesome. That was an awesome spontaneous lecture. And exactly what you just said, like Nellie was saying this last week, like she feels like she's seen so many different types of clear cell that like she always feels like she has to put clear cell in the differential because they can look so many different ways, but that this can help you like stratify, like, okay, what is my likelihood? So that can guide, like if the patient's not a good surgical candidate or whatever it is, they know the risk. And then actually your point about chromophobe, that was something Yvonne also told me. And I said, like, I don't see it in the algorithm. And he said, like, that's something in the paper and they, might add it to the algorithm in the future. But I have had, that's been very useful for me. So when I'm in that oncocytoma chromophobe category, then I will look at the restriction.
Yep. And there is a few more things to be done with CCLS as well, because if you ask Yvonne, the diffusion restriction has to be like, again, high B value, whereas I think most institutions we're performing like 0, 800 or a low B value. So which he kind of hates. And he says that if you use the low B values, you can't rely on that. That's one. The second thing which Yvonne says is that when we're doing the in and a post phase imaging, it has to be 2D and not 3D, because otherwise we might just be missing a bunch of lesions. Then we also need to standardize. Like, for example, in my institution, we use fat suppressed T2, as you're able to see on my screen, for almost everything, whereas he uses non-fat stat. So there's a lot of standardization to go, but I think even if standardized, CCLS is never going to be great at predicting the individual subtypes, but it can be useful for research as well as useful for strategizing depending on institutional preferences. Because urologist community itself, like when I speak to my urologists, they don't have a good sense of where they want to go. Each institute is different. My institute wants to do active surveillance for all masses and biopsy for all masses, whereas like some cases like Cleveland Clinic and others, they're completely opposite. So yeah, it's just exciting.
Very cool. I'm actually amazed that you guys biopsy all your masses, because we don't do that. But and it seems like if it's like a classic clear cell or a CCLS5, like you don't need a biopsy, right?
Yeah, we don't. But my clinicians are like, what's the hurry? We can't take the patient immediately to surgery anyways. Renal masses grow slowly anyway. So what's the hurry? We'll just slowly biopsy and do it. And we just recently were looking at our data, and I think we published, like not really published, but we presented this as SAR as well as we had like 2,500 biopsies of renal masses, in which around half were done with coaxial technique and the other half without coaxial technique. And we were just looking at like complication rates and like whether there is seeding risk or any upstaging risk or anything with one technique or the other. And then we were like, ultimately, it doesn't matter. Choose whatever you want to do, whichever technique you want to do. It's essentially the same. There's no seeding risk in both. But yeah, like we are still working on that database because we have a huge database of renal masses. We are looking to do other studies as well. So that's what CCLS, and I can show you this particular case just because we had a similar case earlier in today's discussion. I just thought I'll just share that as well. So this was a patient with a stage 3 colon cancer, and patient was being initially like, they were thinking that we'll do a neoadjuvant chemotherapy and then like delayed treatment because it was stage 3. And they did a CT, and we see that this CT, it's all normal. Whereas when we look at a subsequent CT, the CT had like new lesions. There's like one lesion here, and there's like another one here. And if you look carefully, there are a few more as well. And now this was odd. Like, first of all, it's not a blush or a hemangioma or anything because it clearly has a contour bulge. So it should be a true lesion. So why do we have true lesions with colon cancer? That was kind of the confusion to us. And so we were like, oh, this cannot be metastasis as well because they're all hypervascular. And maybe is it like neuroendocrine carcinoma, which we kind of missed initially. And that was the initial confusion. And then we did the MR. On an MR, we find that the lesion is slightly T2 bright. And if you look at the non-contrast T1, we're not really able to see that very well, just a bulge. But on the arterial face, once again, it's extremely hypervascular. And we're able to see a few other lesions as well. And the rest of the faces kind of look normal. It's just like ISO. The liver looks very homogeneous. It just continues to be bright. It's not like washing out or anything like that. So then because it was colon cancer, and we use Primovist for a lot of our colon cancers, and we did the Primovist imaging, and it was kind of very interesting. So if you look at the liver compared to other faces, it was very homogeneous. Like, if you look at this, it's extremely heterogeneous. And we find that that particular lesion did show uptake of Primovist in the periphery. And even this one actually shows uptake of Primovist in the periphery of the lesion. Now, subsequently, this patient was followed up, and I think it's kind of almost after a year or so, this lesion and this lesion both are increasing, both have central scars, and the latest Primovist shows that there is uptake in both this lesion as well as this, as well as a lot of other uptake. So the hypothesis with this is that these are all FNHs, and focal nodular hyperplasia are known to develop after oxaliplatin therapy, which is a component of Folfox. And I think there is some literature to show that they're all linked to sinusoidal obstruction syndrome. So oxaliplatin and the other ones can cause SOS. And because FNH basically is some kind of like vascular abnormality is what predisposes to even congenital FNHs anyways, this SOS can predispose to FNHs, which later if the SOS kind of settles down, these FNHs can still, I think, can continue growing. There's been like literature on each of these separately, like, you know, cancer drugs causing SOS and cancer drugs causing FNHs. I think there was an AJR article on oxaliplatin induced FNHs, but I think that's just the entire spectrum of the disease in which it can cause both because that's the common etiology.
This is so cool.
That's a fabulous case.
This is amazing. And I love that the SOS resolved. And also, we've had this debate about like, why do FNHs like suddenly pop up and like, why are they growing? And so I'm going to check out that AJR article, but that's awesome.
Oh, I kind of had it somewhere. Let me see if I'm able to find that. Yeah, article. This one is like from like Alexander Furlan and their group. So FNH hyperplasia after treatment with oxaliplatin, and then they showed a bunch of cases there and something. And yeah, it can become very big and stuff like that. This is the AJR article on that. But there are other articles, like especially the pathology ones, when we kind of look at SOS etiology and FNH etiology is kind of almost similar. So it's kind of, we believe it's one spectrum. We also had a few other cases like this, but I think this was the most dramatic and beautiful one, showing progression of FNH, resolving SOS, and the whole spectrum well.
Very cool.
Yeah,
And were
another
they taken off their chemo between those two imaging studies?
Yeah, it's a slightly older case. I kind of need to look at the.
Oh, no worries. I was just
one-
wondering, like, are the FNHs growing because the SOS resolved or because they're still on oxaliplatin?
Yeah, I don't correctly know the answer to that. If that's something interesting, I need to actually look into the timeline and see what happened. But yeah, off the top of the head, I don't know the answer to that.
Okay, well, that was an awesome case. Thank you so much.